Nancy, hello. Hello, am I audible to you, Nancy? Hello. Hello. Hello.
Hello, sir. Can you hear me?
Yeah, am I audible to you all?
Yes, sir. Yes, sir.
Yeah. Shall we start or we'll wait for 2-3 minutes more? We'll wait for 2 minutes. Okay.
So whatever.
I think we'll
Okay,
start.
okay.
Wait for 2 more minutes. Yeah.
Sure.
Okay.
So you can share your
Screen. Yeah.
screen in the meantime.
Yeah. Right. Okay, we'll start. Nancy, we'll start.
Yes,
Yeah.
sir.
I think is there something wrong with the audio? I think your voice is not very clear. My audio is my voice is clear to you?
It's clear. It's clear. It's my network, sir.
Okay, right. So, good morning, everyone. As usual, this is the Grand Rounds Part 17. We'll start with a short case and then go for proper cases. This is also a good case anyway. This is a 40-year-old lady who fell down and noticed weakness and numbness of entire left upper limb 3 weeks back. She had been on a sling since then, came here since there was only mild improvement. This is the video of the patient. Just got put only 2 to 3 power of the deltoid, 2 power of the bicep, 2 to 3 power of biceps. Triceps was severely weak, only 2 power. Dorsiflexes, matter, I mean, of the wrist, finger flexes, finger extensions, small muscles are all grade 0. The reflexes, bicep, supinator, bicep absent on the left side. Sensation, she is able to feel pain there. He said yes. She is able to feel. Except that area, she said it does. If she's not, the upper arm, she is able to feel. That area she is not able to feel. Vibration is normal in the left hand. What I meant was it is decreased in the thumb, but normal in the left finger. But the wrist is able to feel. It's got impaired joint sense in the thumb and little finger. So that's a finding. I'll summarize the finding to you. Grade 2 to 3 power of the left deltoid and biceps. Grade 1 to 2 power of the triceps. Wrist flexors, extensors, and finger extensors, flexors, and small muscles are all grade 0. DTR all absent in the left upper limb. Sensory system, pain and touch preserved in the left upper limb, except over a small area in the left lower arm. Vibration sense is impaired over the thumb, index finger, and middle finger, but preserved partially over the wrist and normal on the elbow. Joint sense is lost over the thumb and little finger. Now, what is your diagnosis? Anyone who wants, you can unmute yourself and speak. Anyone? Where is the site of lesion for the weakness? Once you can unmute whoever want to speak.
Sir.
Umar is there. Yeah, tell me, Umar.
Is it a pan-brachial plexitis involving from C5 to T1 on the left side?
Okay, you mean to say plexus involvement or root involvement?
It's a plexus involvement.
Okay. It can be in a root avulsion.
Root avulsion, first of all, the one is there any pain?
She is able to feel the pain and is able to feel the touch, not able to feel the vibration distally and joint sense. But
because it is very unlikely to have all the root avulsions in a fall and without involving the other side and without.
No, that's in fact that is more common with root avulsion rather than plexopathy. Usually root avulsion can affect all the roots, depending on the severity of the injury. But you said it's clinically difficult to differentiate whether it's a plexus involvement or root avulsion. Okay. Now, any other opinion from anyone? Then, okay. What investigation would like to do?
What about the harness? Is there any harness on the left side?
No harness on the left side. That's a good point by which you say differentiate the two. Because the distal plexus involvement will not affect the harness, but proximal can produce harness.
MRI, sir? MRI of the cervical spinal plexus.
MRI or you want conduction to differentiate between the two. This is already 30 now. It's the so you have to do conduction first.
Conduction. Okay.
See, this is the conduction value. Left median this CMAP amplitude is low in the wrist, elbow, axilla, and ineligible depth point in the median nerve. In the ulnar, slightly normal amplitude, but we don't compare with the opposite side. And the Ebbs point is ineligible. Decreased CMAP amplitude on the left radial and musculocutaneous from the biceps is not elicited. Now come to the right side. Right ulnar is 10.1. That is, this is 5.5. That means this also affected on the left side. These are all normal on the right side. Everything is normal. FAB is absent on the left median and ulnar. And this is sensory potential. Sensory potential are all normal. Now, what do you think about the site of lesion now?
In that case, most likely it must be the roots.
Okay, root avulsion. Okay. Anyone else you want to opinion?
Sir, I missed the background history initial presentation, sir.
He fell down on the left side and noticed this thing from a height. She fell down and noticed this weakness.
So other side is involved, sir.
Other side is normal. Right upper limb is normal.
Sir, rhomboids and serratus.
That little difficult to this because he was having pain and was on a sling. In fact, I did not examine that part. Difficult to check. Suppose almost complete weakness of upper limb. You have to check the rhomboids is practically difficult.
This possibilities is still a root avulsion, sir.
Root avulsion. You think it's a root avulsion because the sensory potential are normal. Okay. But the point is that the snap sparing cannot differentiate since the patient had normal test sensation in the left. See, the fibers are preserved. It's not totally lost. Only some of the fibers are affected. So in that sense, you will have a normal potential even if it is lesion is in the brachial plexus. You got the point. Only if the patient with anesthesia and the potential is absent, then only you can call it as the lesion is the plexus. If it is present, then only you can call lesion is in the root. You got the point. So with the preserved sensation, we need not have a lost snap amplitude even in the plexus.
Sir,
So this, yes, I think your voice is breaking. Can you repeat it once again?
So it could be a combination of both root avulsion plus brachial.
Yeah. No, in the presence of a plexus involvement, you can't diagnose a root avulsion because everything can be within a combination. Is there something wrong with my audio? I don't know. Are you able to hear me?
Yes, sir.
Okay.
Yes, sir.
Yeah. And,
So all the students are requested to please mute yourself when sir is talking.
okay, right. Now the point is that if the patient has got combined root and plexus involvement, it mimics that of the plexus because snap will be absent. There on that contact, there is superadded root avulsion. You cannot diagnose electrophysiologically. Only if the pure root avulsion with sparing with the brachial plexus, you can tell snap is going to be helpful, where the snap is preserved. But otherwise, it mimic only, combination mimic only that of the plexus. So what do you want now? Differentiate between the two.
Sir, the vibration is involved now, so that then we can differentiate between root and plexus if the snap is preserved.
Yeah, your point is taken, but some fibers are preserved, no? Vibration, some of fibers are affected. But what we are looking is that it's not total affection. So preserved snap does not, if it's total anesthesia only, we can use significance. You totally lost sensation, and then you find that potential is not, is picked up. That means lesion is possible. Otherwise, we can't be very careful. Is pain and touch is preserved in the hand?
SSCP.
Okay, SSCP can be done. That to differentiate whether it's possible and distant. But again, SSCP will also be prolonged, whether it's the plexus, whether it's the root.
The H reflex, sir?
H reflex is can be done from this flexor digito, flexor carpi radii. but very difficult to get. I have not done that. But again, you told this is between plexus and the root, not the periphery and the plexus. The periphery and the root. That you can't differentiate.
And do any EMG?
EMG can't be helpful because EMG is only going to show that we know the muscles are affected. Whether it is in the anterior horn cell or root or plexus, EMG should be going to decrease the innervation pattern only.
Paraspinal should be usually preserved on plexus.
Yeah, that you paraspinal EMG can be to differentiate between the two. Paraspinal EMG can be. That part is good. Okay, that's a good point.
MRI now.
Now, I think MRI. MRI is the one which can differentiate. Root avulsion can be picked up. Now, another point favoring plexus involvement is look at this EMG electrophysiological finding. See, with relatively normal CMF amplitude, Ebb's point potentially is not picked up. Whereas all of the nerves on the right side is picked up from the Ebbs. So it's not a technical problem. If it had been a technical problem, it should have been not on the other side also. But on the left side is easy. That means that shows that there's some kind of a conduction block in the plexus. So MRI was done. MRI was normal, did not show any evidence of root avulsion. And the plexus also is normal. So it's actually neuropraxia involving the brachial plexus. Now, what investigation else you want?
Contrast scan, contrast.
The contrast can be done, but to find out what is causing the plexus involvement, you can take an X-ray. The X-ray shows shoulder dislocation and fracture of the head of the humerus. That is separate. So that means it's unlikely to be due to local problem with the dislocated shoulder pressing on the brachial plexus and causing brachial plexopathy. And the patient improved remarkably well after a period of 2 to 3 months time and follow-up. Okay, any questions in this case?
So in this case, clinically, is it possible to differentiate with whether it's like plexus or a root in
Okay,
this case?
clinically, it's extremely difficult unless you demonstrate. Clinically, extremely difficult. Proximal plexus versus root, very difficult. The only clue may be a corner syndrome, which may not be present if lesion is can't differentiate because in the proximal plexus and the root can also both can produce corner syndrome. You understood what I said? Because the horn, the sympathetic fibers comes out from the common nerve, the anterolateral rami, before it divides it. So a lesion at that point, even the extraspinal region, can sometimes spare the horns.
So the paraspinal EMG would be a helpful.
It's a helpful point, but the problem again with paraspinal EMG in the cervical lumbar region is that you may find some fibrillation even otherwise because of the age-related changes and the cervical lumbar spine. Very often you may find some kind of an innervation finding, but nevertheless that's a good point to differentiate the two. If you find even innervation on one side and not on the other side, actually that is a good point to differentiate if you are doing it after 3 weeks. Here it is just 3 weeks the patient has come. To innervation may not appear immediately, may appear only later. Okay, shall I go to the next case?
Hello, sir. Regarding this same patient, sir.
Yeah.
Sir, in brachial plexus pathology, we take a sensory loss for localization and motor weakness for severity. Sir.
You tell me, yeah.
Sir, in this patient, sensory loss was there confined to, I think, axillary nerve, left small part over the lower arm.
Exactly. Correct. You're right.
Otherwise, sensory is normal, sir, except for that vibration loss over the thumb and finger. Yeah. That also takes away from the complete brachial plexus injury, sir, in this patient.
Yeah, absolutely. You're right. It's not a complete plexus injury. Actually it's a planned plexopathy, but the affection of the motor part is more than the sensory part. Okay, that often occurs in the compression, even if brachial plexus compression or neuralgic hematrophy, The motor affection will be much more than the sensory affection.
Okay, sir. Okay. Yes, sir. And sir, in neuropraxia, sir, in nerve conduction study, usually sensory and motor both usually be normal, sir, or it can like decrease. It can show.
I'll tell you. In the case in neuropraxia, only if it is only confining producing a demyelinating conduction block, distal conduction will be normal. Distal CMAP will be normal. But if some axons have been affected, CMAP will come down. So
Okay,
what
sir.
I am trying to say is that neuropraxia, because he has, in addition to the axonopathy, this patient has got a demyelinating conduction block telling you that the proximal pickup from the Ebbs point is not elicitable. Distally
Okay,
it is picked up.
Okay, sir.
You got the
Okay,
point.
sir.
So
Yes,
that
sir.
tells
Yes,
you that tells you that there is a conduction block in the brachial plexus.
Okay, sir. Okay.
If it had been axonopathy, it should not have produced that kind of difference between proximal and distal stimulation.
Okay,
And
sir.
CMAP will be uniformly low, whether it's stimulated proximally or distally.
Okay, sir. Okay, sir. Okay. Thank you, sir.
Okay. Then shall I
So
go
the
to
shoulder dislocation can cause the pan-brachial plexus.
Yeah, it's not very common. Your disease is common. Sometimes it may be only axillary, sometimes it may be common trunks affected at the middle and lower trunk. Sometimes pan-plexopathy can happen. It's very well discussed. Yeah.
Sir, why the MRI hasn't picked up even after so many, a couple of weeks, sir?
MRI may not pick up the distant lesions in the plexus, no. I said, as Umar said, we had asked for a contrast study, which did not do because the diagnosis was obvious by the shoulder X-ray. Even plexitis, you may not find anything in the MRI. Take, for example, neurologic amyotrophy involving the bone or a diabetic amyotrophy producing plexopathy, you may not find. You may find, you may not find. But root avulsion, invariably you find there is, you meant the CSF localization coming out from the roots, along the root sleeve. Pseudomeningocele, you definitely will see.
So the axil nerve comes before the plexus is formed at the or after the plexus is formed.
Which nerve?
Axillary nerve, sir.
Only
On the cord, right?
yeah, it's a part of the posterior cord of the root brachial plexus. So it's only the part of the distal part of the plexus. It's a part of the plexus.
Only the long thoracic nerve and the suprascapular nerve.
Suprascapular also has that. Right? The nerve to rhomboids and the nerve to the long thoracic nerve are the ones which you look for to differentiate whether the trunk versus the root of the brachial plexus. But remember, this is not between the root and the trunk. See, even in plexus involvement, you can have affection of the long thoracic and rhomboids. But here the root or the plexus is affected. But the point is that differentiate root avulsion from plexus, this is useful. Okay. See, in the proximal plexus involvement also can produce affection of long thoracic and rhomboids. Differentiate root avulsion from this thing is useful. Because one is intraspinal, the other is extraspinal. There it will be useful. Okay.
Sir, how you treated this patient, sir? Any treatment wise, sir?
Treatment, we give a short course of steroid and patient injury.
Okay, sir.
So the preserved SNAP is still difficult to explain.
Yeah, it can be. That's only because that's what I said. The sensory system is not totally affected because touch fibers are preserved in him. That means some of the fibers are preserved. Only thing is the large conducting. Some of the fibers are affected. That is a posture for the joints in this affected, but vibrations affected distally only. They're not throughout. All of the nerve vibrations intact. It's affected only in the thumb, index, and ring. The other areas is spared. What you said is correct. Logically, large fibers are the which carry the vibration and joint sense. But they're not totally affected. That's the thing we have to pursue.
Okay.
Otherwise, this electrophysiological picture is associated for the root avulsion, as already been. But obviously not avulsion because patients will go total. Okay. Shall I go to the next case? Yeah.
Okay.
Let's have the short case. This boy is a 15-year-old boy, had been having problems for the last 10 years. It's clumsiness in the right lower limb on prolonged walking for the last 10 years. It's not present at first. That's only complaint. He took some treatment without much benefit, and so some other treatment is undergoing now. Examination shows it's normal, and the bedside examination is normal, no abnormality. So let us see the video of the patient. Control rapid movement is okay with the right lower limb and left lower.
History, if you don't mind, just because I just missed it.
So only history is it's got when he prolonged walking, he does some peculiar abnormality to the right lower. He said clumsiness to the right lower limb on prolonged walking. For 10 years, non-progress.
Okay, right.
Examined bedside is normal. This is the rapid movements are also normal. And see how he is walking. There's some clumsiness on walking on the right lower limb which you can do. But see the continue to watch his gait. What happens progressively? There is two more words now on the right lower limb. See how it now is getting more adducted and extended rotated. They become more flexed now. It's crossing to the opposite side now the right leg. It becomes more difficult to work. It becomes more clumsy in work. It's more flexed and toe goes into, foot goes into plantar flexion and thigh goes into adduction. With the way he could walk, it's tremendous. More difficulty in putting his leg forward. And at the same time, examines the upper limb did not disclose any abnormal posture. This is immediately after the exercise. So, what is the likely diagnosis in this patient?
Paroxysmal dystonia.
Hemidystonia.
Paroxysmal exertional dystonia.
Okay, exertional dystonia. I mean, the idiopathic variety of paroxysmal dystonia.
Yeah.
Sir, he has problem even from the very first, even the starting of this walking. So it is not just because kinesiogenic means it has to start from the initial outset itself.
It's not kinesiogenic because it persists. It occurs only when walking, not when he suddenly gets up and all. It does not begin. When he walks for some time, it starts getting.
Even the upper limb, there is some amount of dystonia.
Not the same. Maybe the subtle, maybe there were not very convincing. It's combined as lower limb, but lower limb is predominantly upper limb, maybe subtly.
It could be DRD also, dopa responsive dystonia also.
Okay, pretty good. Then what is paroxysmal? Okay, so how do you treat this patient?
First try clonazepam, and then if he's not improving, try levodopa, carbidopa.
Okay. So the possibility of paroxysmal is other condition you have to keep in mind is GLUT1 deficiency.
Yeah, GLUT1 deficiency.
Can produce paroxysmal chorea as well as dystonia. And hyperparathyroidism, never forget, can also be sedimentary treatable condition. They can come with paroxysmal dystonia. Means something like hyperparathyroid spasm can be paroxysmal. So what investigation you said? You need serum calcium was normal, MRI was normal. Serum sugar was done after exercise to rule out any GLUT1 deficiency. That's off the norm. Now, on follow-up, the patient improved totally with treatment. What treatment?
Levodopa.
Correct, perfectly right. Dr. Joy, you said that there's a patient in levodopa who has completely improved on levodopa. So, DRD presenting it, I'm seeing for the first time DRD presenting as a paroxysmal dystonia. Now just two, three sentences only from later. There are many conditions that can cause. One is a classical paroxysmal excited dystonia. The mean age is 5 years. By definition, prolonged or maintained exercise normally triggers the episode. Most commonly in the dystonia is the feet, followed by hemidystonia. Then glutamate deficiency. Several mutations in the glutamate SLC2A1 gene had been reported as an isolated syndrome or accompanied by other features of glutamate deficiency like especially epilepsy. It can be triggered by prolonged exercise, fasting, stress, and anxiety. Then pyruvate dehydrogenase deficiency can also produce, apart from dystonia, other features of lactic acidosis and encephalopathy. Here again, episode dystonia is sometimes triggered by exercise, others by stress, a warm bath, or no identifiable trigger. There is ECHC episode mutation, then DRD. Besides Doppler responsive dystonia, GCH mutations are reported as cause of paroxysmal exercise dystonia, either in isolation or embedded in a more complex phenotype. This is another condition, ADC55, where patients typically have childhood onset of mixed persistent hyperkinetic movements, including chorea, dystonia, and myoclonus, characterized with following features: axial hypotonia, orofacial jerks, no true myoclonus, sleep-related paroxysmal dystonia and painful dystonia, marked fluctuates the frequency and severity. Then can also occur in rapid onset dystonia, Parkinsonism, alternate hemiplegia, childhood, and composed syndrome. So this is from the literature only. So the thing you have to remember, don't forget hypocalcemia and DRD and okay.
Sir, is it possible to have a heavy dystonia in DRD?
Oh yes, a DRD can present with various presentations. Even writer's cramp can present as DRD. Adult onset kyphoscoliosis can be a presentation of DRD. Adult onset Parkinsonism can be presentation of DRD. So the variations, but even cervical torticollis is described as a part of DRD. So that is for any dystonia, they say that whatever with the dystonia, give a trial of levodopa, especially of childhood onset, because the presentation can be so varied.
Sir, do you think the upper limbs are normal, sir? Because there is definite posturing while walking of the
Correct.
upper limbs.
Yeah, correct. Upper limb is normal. You think there's upper limb dystonia posturing is there?
Yes, sir, affected, sir. Can you show again, sir?
Okay. Maybe then I was concentrating on the lower limb. I don't know, look at the upper limb. You may be right. I was only looking at the lower limb interested. I was this worsening or not. His complaint was that he's worsening on exercise. I was mainly watching the lower limb. But at the end of exercise, I did not see much because upper limb was doing, every action was doing normally, rapid movements. Anyway, it may be there. Can have hemidystonia. So we'll go to the next case. Okay. Any questions? Shall I go to the next case?
Next case.
Yes, sir.
Yes, sir.
Yes,
Yes,
sir.
sir.
Okay. Then a 54-year-old diabetic man with difficulty in walking for the last 3 months. There's no numbness or bladder problem. I don't know, some of you must have seen this video earlier, but it's a good case. He had power, the upper limb is about grade 4 all throughout, even though he did not complain any weak.
കൈക്കൊരു ബലക്കുറവായിട്ടൊന്നുമില്ല. മുറുക്കി പിടിച്ച് നല്ലപോലെ മുറുക്കി പിടിച്ചോ. ഇത് മുറുക്കി പിടിച്ച്
Good power.
മുറുക്കി പിടിച്ച്
He can overcome the
നൂർത്തെ കൈ മടക്കിക്കേ, ഇത് മടക്കിക്കേ, ഇങ്ങനെ കാണിച്ച സ്പീഡിൽ ഒന്ന് കിടക്കാമോ? ഈ കാല് നേരെ പൊക്കിക്കേ.
right terminal is 4 plus. Left is more weak than the right.
ഇവിടെ സപ്പോർട്ട് എടുത്തോ, കുഴപ്പമില്ല. ഇവിടെ പിടിച്ചോ, എന്നെ ചവിട്ടി മാറ്റണം.
The action is put down on the right side,
നൂർത്തെ
weak on the left side.
ചേട്ടൻ നോർത്ത് 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 ഈ
Go to
പാദം
notification
മുകളിലോട്ട്
page.
Yes, sir.
പത്തി മുകളിലോട്ട്
The
ഇരിക്കണം.
video is
video
not
is
moving,
stuck.
sir.
Video is not moving?
Not
Sorry.
moving, sir.
Okay, okay. Do one thing. I will exit and then I'll share it once again. Are you able to see the moving video now? Is it moving now?
No, sir. Not moving.
No.
കൈക്കൊരു ഒന്നുമില്ല.
Yeah, it's not moving now.
It's not moving.
Not moving. So I'll completely exit once again. Just 1 minute and then exit completely. Can you see my slide now?
Yes, sir.
Yeah. Now I'll start. Let me see the video is moving or not. What about now?
Now it's moving.
Okay.
Now it's okay.
കൈക്കൊരു ബലക്കുറവായിട്ടൊന്നുമില്ല.
We never complain of weakness in the upper
നല്ല കൊല്ലം മുറിക്കും.
but there is mild weakness on both upper limb, slightly more on the left side,
മുറുക്കി പിടിച്ച്.
mainly in the distal part.
കൈ നോർത്ത് നോർത്ത് കൈ മടക്കിക്കേ. ഇത് മടക്കിക്കേ.
That is normal.
ഇങ്ങനെ കാണിച്ച സ്പീഡിൽ ഒന്ന് കിടക്കാമോ? ഈ കാല് നേരെ പൊക്കിക്കേ.
Right locally proximus is the good power.
പൊങ്ങട്ടെ പൊങ്ങട്ടെ. ഇത് പൊക്കിക്കേ.
That is more weak on the left side.
ഇവിടെയാണ് സപ്പോർട്ട് എടുത്തോ, കുഴപ്പമില്ല. എവിടെ പിടിച്ചോ.
Quadriceps
എന്നെ
also
ചവിട്ടി
on the right side, but weak on the left side.
ഇത് നൂർത്തെ നൂർത്തെ ചവിട്ടി നൂർത്ത് നൂർത്തെ നൂർത്തെ. ഈ പാദം മുകളിലോട്ട് എടുക്കണം. പത്തി മുകളിലോട്ട് ഇരിക്കണേ.
The dorsal plexus is bilaterally weak, more on the left
മുകളിലോട്ട്
side.
എടുക്കേ. തണ്ടവരിൽ പൊക്കിക്കേ. ചവിട്ടിക്കേ. ഈ കാല് അകത്തി പിടിക്കണം കേട്ടോ. അകന്നിരിക്കണം. അടുപ്പിക്കാൻ സമ്മതിക്കില്ലേ.
Adductors are also weak, more on the left side than on the right side.
ഇരിക്കല്ലേ.
Adductors are weak on the left
എടുപ്പിച്ച്
side.
വെച്ചോ. കീഴ്പോട്ട് തള്ളി.
Hip flexors is again weak bilaterally, but more on the left side.
ഇത് കീഴ്പോട്ട് തള്ളി. ഇതിനെ കൊടുക്കണ്ട കേട്ടോ.
Again, hip flexors are diminished on the left side compared to the right. There is some suggestion of an inverted supinator. You can make out the supinator.
Nothing indicated.
The left side it's not seen. Down reflexes are absent. Inject. Right side is brisk on the right side. Left side is elicited but less compared to the
Cut
right
now.
side.
Cut now, sir.
2 plus on the left side, 3 on the right.
Now it's not moving.
This happening. Let us see. See the problem with our.
No, sir, it was moving, sir.
Yeah,
It's moving, Joy.
no. I will tell you one. Once again I will.
Maybe something wrong with my this thing then, connection. Sir, continue ചെയ്തോ ഞാൻ
It was moving, sir. You can continue, sir.
You can.
Yeah, just anyway I'll read. Just 1 minute. I close. Okay, can you see my video now? Okay, start playing from where I left. Can you see it moving?
Yes, sir.
The reflexes upper limbs are normal. Right upper limb, left upper limb is negative. There is a suggestion of inverted supinator in the right.
രണ്ട് പകുതി മടക്കിയിട്ട് അതിങ്ങനെ ഇരിക്കട്ടെ. അങ്ങനെ കൊടുക്കണ്ട.
Okay, taps on the left side. Abdominal reflex is absent. Right side is placed. Left side is present. Let's compare to the right. I think both are absent in the back. There is contained plantar bilateral.
ഇത് അറിയുന്നുണ്ടല്ലോ അല്ലേ? ഇതോ 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 ഇതും അറിയാം.
The gate agree with the patient.
ചേർത്ത് നിൽക്കും. സാരി ചേർത്ത് നിൽക്കും.
Okay. So, summarizing the finding, grade 4 plus for all upper limb muscles, lower limb grade 3 to 4 in proximal muscles, more on the left side. Close flexors are weak bilaterally, again more on the left side. Plantar flexors are normal. DTR right upper limb is 2 plus, Cori inverted supinator check on the right side. Left side all DTR diminished, 1 plus. Lower limb knee check is 3 plus on the right side, left side is 2 plus. Angle check absent bilaterally. Abdominal reflex absent, plantar upgoing, sensations normal. So what is the likely diagnosis in this patient? You want to say the findings once again? I can show.
Cervical myelopathy.
Okay, cervical myelopathy, probably radicular myelopathy because the left upper limb reflex are diminished compared to the right side. Okay. Any other thought? Any other possibility from anyone? Hello?
Radicular neuropathy, sir.
Pardon, tell me.
Diabetic radicular neuropathy may be the first possibility.
But his plantar is upgoing.
But the predominant involvement of the proximal muscles of the hip, predominant involvement of the proximal muscles in the lower limbs and
So
left
you
upper
will say superadded plexopathy? Yeah, that's possibility cannot be ruled out. Yes.
So he has a dragging gait, and the knee flexors are weak, as well as he has weakness. He has reflex loss mainly on the left side with upgoing plantars. So probably he has got a predominant myelopathy with multiple roots affection mainly on the left side. So it cannot be explained by by a plexopathy or by a diabetic neuropathy. So.
Right. Okay. So any other possibility?
So when the reflexes are diminished on the left side, we can't say the right side is brisk comparatively. So except for the plantar extensor, everything can be explained with diabetic radicular neuropathy.
But you know, called diabetic radiculopathy, as you said, the weakness is more on the left side, and that reflex is less. It's a radiculopathy. But the upper limbs are also reflex is decreased. How can radiculopathy be confined only to one side of the body, and that too, there is no sensory finding in this patient?
But all the limbs are affected. The 4 limbs are affected. Left is more than maybe asymmetric radicular neuropathy.
But what is the evidence of radiculopathy on the right side? In fact, the reflex is brisk, except for the angle jack loss, which could be due to the diabetes. Other reflexes are all brisk on the right side. With even the finger pressure is also brisk. So brisk plus outgoing plantar, you would definitely take it as compared to a pyramidal lesion, at least on the right side.
Was his gait just dragging or something more than that?
No, that is up to you to decide.
Because
So the gait is
his knees were looking slightly flexed sometimes. Sometimes his knees were going into hyperextension, especially on the left side.
So what do you think your possibility?
more of a proximal muscle involvement in the lower limbs.
Yeah, proximal muscle is weak, I told you. Right lower limb is also weak. Left lower limb also much more weak than the right side. And even the dorsal are slightly more weak on the left side.
That favors radiculonopathy. So involvement of proximal more than the distal.
Yeah, that favors an element paralysis. You said it's correct.
Sir, he has a knee flexor weakness in addition to the gross pyramidal-like involvement on the left side. Correct. With loss of reflexive, that too predominantly confined to the left upper and lower limb. Correct. So I would still consider a cervical lesion, which is involved the pyramidal as well as the element the reflex fibers on the left side.
Okay. We'll do some other possibility of plexopathy or some other mechanism display the reflexia on the left, so hyperreflexia on the left side. Angle jack you can leave it out because it's part of the diabetes. Anyway, then we'll go to the what investigation you want now.
I want an MR of the cervical spine.
Okay, MRI shows a cervical disc at C5, C6, some hyperdensity within the cord. Can you make out the hyperdensity? I'm not sure that you can make it out. You can make out the hyperdensity here in the posterior part. Here also you can make out hyperdensity.
Not able to see the film, sir.
You can't see the film?
No.
Stuck, sir.
You cannot see it.
A slide not moving, sir.
The slide got stuck.
After the deep tendon reflexor does not move a bit.
Okay, what is happening today? I don't know. You can't see the films now, okay?
No, sir. No, sir. Can't see.
Okay.
So this is still on examination, sir.
On examination only. I don't know what may some problem with the net. No, is it moving now? No, it's not seen, no?
Yeah, no, sir. No.
Yeah. Sometimes there's a message coming, you are not seen. That's some problem from that server there only. From fine meeting, I mean, the person who arranged the meeting. Anyway, you can see the films now.
Yes, sir.
Yeah, there is a disc there, and there's some hyperdensity within the cord.
Yes, sir. In the C5 level.
Still cut. Showing hyperdensity in the posterior part. Is the films moving now?
Yes.
Okay. Thank God. Then you can have hyperdensity again. You can find the posterior part of the cord. Now, what do you want now? What do you want to do now?
I want a MR.
Lumbocytic spine.
No, MR of the dorsal cord. Dorsal cord both axial and sag.
Full spine MRI.
Dorsal cord was not done.
Lumbocytic spine also.
Lumbocytic spine also not done. That's why it's not done.
ENMG, sir.
Yeah. Right. Now I want you to see the gate once again. This, as Joy was pointing it out. Look at the gate. The clue is the gate. Look at the level. It's got a foot drop, but apart from foot drop, the knee goes into hyperextension. Did you see that? It goes backward. See that? what do you get in cortices weakness is buckling. It also cortices also can produce this kind of phenomenon. It's called cortices A, where the knee goes into hyperextension in when walking during the swing phase, when the not the swing phase, when the patient stands on the with the foot on that side, and that it can occur in cortices A. This can occur only in element parameters. Because the human being there is plasticity will not get this kind of phenomenon. The limb will be straight. Somebody goes into hyperextension and walking means it is element. So that means this patient has got definite element weakness on the left side. So without any sensory element weakness, one possibility you have to keep it is either it's a motor radiculopathy, as always telling, or a diabetic plexopathy, or anticonvulsiveness. These are the possibility you have to keep it. So cortices weakness. So we did NCV and EMG in this patient. This NCV shows low CMAP amplitude from peroneal, tibial. The upper limit was normal, and FAVs are also absent in almost all the nerves at the upper and lower. I don't know how to explain that thing. And zonal sensory was absent, obviously because of his diabetic neuropathy. Now let's see what it did now. The EMG from the APV showing the upper limb, the fuse did from the cortices. Again, the fuse replaced. From the other thoracic paraspinal, again the replaced. So it can diffuse all over the body, and on re-examination, ultrasound, you could pick up precipitation from the upper limb, back of the muscles. This person, you know what happened? He progressively worsened over 2 to 3 months' time, and he succumbed by respiratory failure in 3 months. This person was no more after 3 months. So rapidly progressive, was admitted there with ventilator for some time, and then it's a case of an ALS. The fluid suspect initial person had something like a radiculomyelopathy, as Mohan was talking, because absent diminished upper limb reflexes and pyramidal sense below. The lower limb could be due to some asymptomatic, so it can be considered. But the cortices A was the one which is strikingly against all this. That's what we thought to be element least in addition. Any questions on this case?
So the patient had also on the video is showing a mild wasting of the upper limbs, so arm region.
Yeah, yes. Perfectly right. Mild wasting of the small muscle limbs.
Should we evaluate for the secondary causes of MN disease for such a rapidly progressive disease?
Yeah, last time also showing a case of MND which is rapidly progressive. It's also another case. Some of the MNDs are very rapidly progressive. I don't know why. I even see the acute presentations of ALS.
So,
Okay.
sir, is it something like a Mills variant, something like that?
Yeah, most likely it is compared to the left side, like a Mills variant of MND. But in Mills, this can't be called as Mills variant. It is ALS itself, because the Mills variant, it is the pyramidal sense are more on one side. Here is element findings are there on one side. Just like any other MND, you can have element patchy element. Mills variant.
Clinically, any fasciculations were there, sir, clinically?
Pardon? Yeah, there was profuse fasciculation.
Fasciculation.
I did not show the fasciculation. The profuse fasciculation was there after examining the patient. He did not complain. We examined again after undressing. Then he found he has the fasciculation.
That cervical MRI changes because of compression there, sir?
No, right. That there is some hyperintensity. There is a compression, but totally unrelated to the problem.
Okay, sir. Okay, sir.
Yeah, probably could explain the diminished pressure in the upper limb. Probably can explain because they really good power. good power of the upper limb with relatively decreased pressures compared to the right could be due to that associated radical. But finding out again if the hyperintensity is posterior part of the part, that cannot explain the weakness or pyramidal weakness in this patient.
Okay, sir. Okay.
But absent abdominal reflexes are due to diabetic neuropathy.
That's difficult to say. He may be having a assembly cervical and a myelopathy, as is already true. But usually in MMD, you don't find absent abdominal reflex. You won't find absent. But here it is. So those are the tricks, Those are the things which you think away from MND. From seeing the first patient itself, we not straight away go to MND. Absent abdominal, asymmetrical presence and all, and inverted supinator on the right side. Naturally, one may consider a compressive myelopathy cervical cord. But there is something which takes you away from the localization. That should lead you to think other possibilities.
Then the needle EMG should be must for every case of radical neuropathy, no, sir?
Yeah, I did not get the point.
So if needle EMG was not done, then we could have missed the case, no? So needle EMG is a must.
Yeah, you could have missed the case. Definitely, you could have missed the case. Okay, shall we? This is the how that buckling can occur in. Sorry, not buckling. Hypertension occurs in cortical weakness. There are very many explanations. I think to understand this, you should not little more detail go into the mechanics of walking. But I just tell the explanation just now, whether even if I'm not difficult to understand. That is, one explanation is that weakness of cortisol results in weakness of knee extension. Here, active contraction of the soleus may help to pull the leg backward, passively extending the knee. The other thing is that there's a compensating mechanism. With corticeps weakness, the individual may lean forward over the corticeps at the early part of the stance phase as weight is shifted onto the stance leg. Normally, the line of force, that is a central gravity, falls behind the knee, requiring corticeps action to keep the knee from buckling. By leaning forward at the hip, the center of gravity is shifted forward, and the line of force will now fall in front of the knee, making the patient hyperextend of the knee. Anyway, this is the explanation. Whatever be it, you remember this is the explanation corticeps weakness. The other situation where you can have hyperextension of the knee is the gastrocnemius weakness. Remember, not the plantar flexor weakness. The soleus is weak. You get flexion of the knee by walking. This I had told 2-3 cases I had shown earlier. The patient walks with flexed knee. You suspect a plantar flexor weakness like spondyloarthropathy and all. There it is due to the soleus weakness. Gastrocnemius alone is weak. That's the rare condition. You can get again hyperextension of the knee. Gastrocnemius, on the other hand, has its origin above the knee joint. It's not only a plantar flexor but also flexor, unlike soleus. It is originating from the femur. It helps to stabilize the knee on standing and prevents hyperextension. Hence, gastrocnemius weakness results in weakness of the knee flexion as well as weakness of the plantar flexion. Hence, an isolated gastrocnemius weakness without weakness soleus, the knee hyperextends on standing because the loss of action, the flexion action of the gastrocnemius on the knee. Okay. We go to the next case. The story of a 64-year-old man. He was operated for right frontal meningioma 15 years back. Presently has come with imbalance in walking for the last 6 months. According to his wife, it was there since the time of surgery, but got aggravated for the last 6 months. So, imbalance in walking for the last 6 months. Whether it's only 6 months or longer, we don't know. But according to the wife, it was aggravated anyway for the last 6 months. It's a vocational presbyterian in micturition for the last 2 months. This is the finding. He has it's a short video. It's got asymmetric stature. Are you able to see the video now?
Yes, sir.
Okay. Ocular movements are normal. Can you make out the nystagmus part? I don't know.
എൻ്റെ
It's a
പേര്
gaze of nystagmus.
നോക്കിത്തട്ടെ
Motor power on normal is mild incoordination, not very convincing, very mild.
ശരി അച്ഛൻ എഴുതി
Otherwise, lower limb, everything is normal. Now look at the gait of the patient. Rhombus mildly positive.
ആക്ച്വലി നടന്നു ഒരു കാലിന് മുമ്പിൽ കാല് വെച്ച് നടക്കെ
No
ഒരു
drop the
മുമ്പിൽ വെക്കണം
better big eye closure. Tandem walking is the better.
കണ്ണു തുറന്നോളൂ കാല് നോക്കി നടക്കണം നടന്നു ഒന്നുകൂടെ നടന്നു ഇങ്ങോട്ട്
Now the video stuck, sir.
I'll say once again. Is it moving now?
Yes, sir, moving.
Yeah.
Now it's more.
ഒരു കാലിന് മുമ്പിൽ കാല് വെച്ച് നടക്കെ ഒരു കാല് കണ്ണ് മുമ്പിൽ വെക്കണം
That's all the video in this part. Short video.
കാല് നോക്കി നടക്കണം നടന്നു ഒന്നുകൂടെ നടന്നു
Okay. So he has got imbalance while walking. Mild got the upper limb and gaze of nystagmus. No dysarthria, motor system normal, DTR normal, sensations normal, no limb ataxia, gait ataxia is present. So, what is the clinical diagnosis you would like to make in this patient?
So, late onset cerebral ataxia.
Late onset cerebral ataxia. Probably subacute or chronic, we don't know. According to the wife, it may be chronic. Whatever it is progressive. 6 months is there. So, you have to come to the possibility of subacute progressive ataxia or a chronic progressive ataxia. That's said correctly. So, the possibility is considered over a CA. Subacute cannot be ruled out. So, one possibility paraneoplasty, anti-JD antibody. So, what investigation you want now?
X-ray chest.
For X-ray chest,
MRI. Right.
Okay. So, MRI the brain. I'm showing the MRI. I will not tell you the finding. Go on seeing the MRI. This is the flyer sequence. Cerebellum is normal. No cerebellarity. The further pictures in the cerebellum, the coronal cut on the brain. The ventricle is slightly dilated. This is the sagittal cut again showing the picture. This is a diffusion weight. So, what is your impression now? You want to see the films once again? I can show.
The frontal cuts, you want to see.
I also the frontal cut. Yeah, yes.
This cut.
Yeah.
The high the parasagittal weak, the high.
I didn't hear you.
The upper part of the parietal lobe and the frontal lobe, the sagittal can't see. So some hyperintensity and hyperintensity can be seen.
That's normal. I only concentrated the finding where it is, where the abnormal finding was there.
This
cerebellar are prominent, no?
This vermin atrophy, sir. Vermin atrophy.
See, in the vermis also, it normally looks like this only. It appears like atrophy, but not really vermin atrophy. Okay.
Cerebellar atrophy is there, no?
I'll tell you, I also thought, just like you said, I did not find any abnormality in this video, just for the one look of it. But then the radiologist pointed out the abnormality too.
Has got
I'll tell you what is abnormality.
Beaked bird appearance.
Here also you can find the abnormality. This I gave a clue. I'll come to that later. Now look at this cut. Do you find anything there in this area? The midline region there. There should not be a lesion there. Some abnormality should not be there. Normally that will be CS. And again here there is an abnormality. And look at the sagittal cut here. There is some small rounded thing here as well as here. So this radiologist picked up that's not normal. You say you wanted a contrast study to be done. I'll show the contrast. This is the contrast. See, this is wait, let us see the pictures first. So this is the lesion here, this is the contrast. So this all depends upon the good radiologist, and we also sometimes go for contrast studies. This is a contrast enhancement. This is again, you can find the previous picture which I shown, that is enhancing with contrast. Again, small rounded thing here, anterior and posteriorly. See what is happening there? That also is enhancing, and the dura is also enhancing. The basal dura is also enhancing with rounded thing in posterior anterior. Here the basal dura is also enhanced. Another cut showing that. Then this is the axial cut contrast, again showing enhancement in the subfrontal region near the crista galley. Again, you can make it very clear. And you can find out the dural enhancement.
Chronic pachymeningitis.
Let's say chronic pachymeningitis. So what is it? Idiopathic pachymeningitis or some other thing you have to keep in mind?
Could be a tumor.
CSF can tell you.
Yeah, it's some nodularity is there. No, it's not. See, there's some bumpy pachymeningitis. When you get bumpy pachymeningitis because of granulomatous condition or a malignancy or a lymphoma, things like that, rather than a classical idiopathic pachymeningitis. So this thing you have to keep that possibility strongly in mind. So what do you want? CSF. These are the possibilities kept. Tuberculosis pachymeningitis, sarcoid and vaginous IgG4 disease. And lastly, carcinomatous lymphomatous meningitis. So CSF showed in 46, total count is 46, 85% lymphocytes, poly 15, protein was 86, sugar normal, 45, across the sugar of 130, and CSF ACA level was normal, ANA profile was. What do you want now?
CSF for malignant cells. And peripheral smear.
Peripheral smear normal.
Do a meningeal biopsy.
No, the thing is that subsequently, after saying this, I started asking about whether past family is tuberculosis and all. The wife said he himself had permanent tuberculosis 2 years back. He just treated. That never hit that. They never diverted that history. So he had past history of permanent tuberculosis, now completely seen as problem of gated malignancy. And he was only they were only telling him about the portal meningioma which is suffering. This tuberculosis which just happened 2 years back, they ignored. So that's a clue. He has put on anti-tuberculosis drugs and improved remarkably after 2 months. Yet everything improved. He came for follow-up after 4 months with talking. So this is how sometimes patients can tuberculosis meningitis, pachymeningitis can present. It totally can take you away from. Initially, we thought, as you all thought, it was some kind of a progressive ataxia. He no headache, no fever, nothing. He gave this. He gave only discomfort.
So, what could be the cause for his ataxia in this case?
Yeah, that's a good question. I was also wondering why should ataxia occur. It's not with the heterocephalus. Heterocephalus will never produce distractions. So what is happening here? Probably the pachymeningitis is compromising the cerebellar somehow. That is the only way you can explain that. But follow up that also improved.
Was he still on anti-epileptics like Eptoin or something?
No. That is the first thing to clarify was, as you said, was he on Eptoin or no? He is not on Eptoin.
Okay.
Shall we go to the next case or wind up?
One more case.
One more case. Okay. 62-year-old lady developed acute onset of vertigo, diplopia, and ataxia with different swallowing. It's a good case. Now let's look at the history once again. Acute onset of vertigo, diplopia, ataxia, and difficulty in swallowing. Look at the video very carefully.
നേരെ മുകളിലോട്ട് നോക്കിക്കേ. ഇവിടെ നോക്കാം.
I must the patient look up. He's not able to look up.
ഇവിടെ നോക്കിയാൽ മതി. if and left eye is down compared to the right eye. Okay. മുകളിലോട്ട് നോക്കേ. There is no. വലത്തോട്ട് നോക്കമ്മ.
Ask you to look to the right side now.
അറ്റം നോക്കിക്കേ. ഇടത്തോട്ട്
Left
നോക്കമ്മ.
eye slightly down compared to the right
അറ്റം
side.
നോക്കി. ഇവിടെ നോക്കമ്മ.
Left side is not able to look fully to the left side.
ഇടത്തോട്ട് നോക്കമ്മ. അറ്റം നോക്കി. ഇങ്ങോട്ട്
And the left
നോക്കമ്മ.
side is not
ഇടത്തോട്ട്.
fully abducting compared to the direction of the right
ഇങ്ങോട്ട്
side.
നോക്കിക്കേ. Right case is okay. Left നോക്കമ്മ.
He looks towards the left side, is not able to move fully.
മുകളിൽ ഒന്നുകൂടെ. Know what I'm going to do? Two things. Ma. No, not in also. കണ്ണ് മുറുക്കി അടയ്ക്കമ്മ. Pels phenomenon is
absent.
That is one point. മൂക്കിലോട്ട് നോക്കമ്മ. നോക്ക്.
Convergence also is
നോക്കിക്കേ.
defective.
നോക്ക്. നോക്കിക്കേ അമ്മ. അറ്റം നോക്ക്. അറ്റം
Able
നോക്കിക്കേ.
to converge on the left side, not
വലത്തോട്ട്.
fully on the right side.
ഇടത്തോട്ട്. അറ്റം നോക്കിക്കേ.
You look towards the left side. Both are not fully moving well, but left is more restricted.
ആ പറ. ആ.
Bilateral parallel restriction.
Bilateral decrease ആണല്ലോ. ആ. ആന്ന് പറഞ്ഞേ.
Project is absent.
അടച്ചമ്മ. പതുക്കെ തുറന്നേ. വാ തുറന്നേമ്മ. ഇത് തമ്മിൽ വ്യത്യാസമുണ്ട് അമ്മയ്ക്ക്. എവിടെ കൂടുതൽ?
It's a decreased pain on the increased pain on the right side.
ഇതും തമ്മിലോ?
That may decrease on the left side.
അവിടെ കൂടുതൽ. ഇപ്പോഴും അമ്മ ഈ കുത്തുന്നതും ഇതും തമ്മിലോ?
Is better felt on the right side.
അമ്മ മെല്ലെ വരലേ തൊട്ടെ. അമ്മയുടെ മൂക്കെ തൊട്ടെ. ഇന്നോട് വരലേ തൊട്ടെ അമ്മ. ഈ കൈ കൊണ്ട് ചെയ്തേ. ഈ കൈ ഇടത്തെ കൈ കൊണ്ട് പൊക്കിക്കമ്മ. ഇനി വരലേ തൊട്ടെ അമ്മ. വരല് ഇനി മൂക്കെ തൊട്ടെ. അമ്മയുടെ മൂക്കെ തൊടെ.
Smile incarnates the left left.
ഒന്നൂടെ വരലേ തൊടെ. ഇനി മൂക്കെ തൊടമ്മ. മൂക്കെ തൊടെ. ഓക്കെ. വീക്ക്നെസ് ആയിരുന്നു കിട്ടിയില്ലല്ലോ. മുറുക്കി പിടിയമ്മ.
Cover is grossly normal. Standard left seems upgoing. Very convincing. So, do you want to see the video once again? Do you want to see the video once again with respect to the ocular movement? Yeah, I'll show you.
നേരെ മുകളിലോട്ട് നോക്കിക്കേ.
The master pedal look up.
ഇവിടെ നോക്കിക്കേ.
Not able to look up.
ഇവിടെ നോക്കിയാൽ മതി.
Eyes are tonically deviated down.
Okay.
Left eye is more deviated down than the right side.
There is no. വലത്തോട്ട് നോക്കമ്മ.
To the right, is able to stick to the right side.
അറ്റം നോക്കിക്കേ. ഇടത്തോട്ട് നോക്കമ്മ.
Left side is not able to
ഇവിടെ
look.
നോക്കമ്മ. ഇടത്തോട്ട് നോക്കിക്കേ.
Bilaterally
ഇടത്തോട്ട്
restricted,
നോക്കമ്മ.
but
അറ്റം
more
നോക്കി.
on
ഇങ്ങോട്ട്
the left
നോക്കമ്മ.
side than
ഇടത്തോട്ട്.
the right side.
ഇങ്ങോട്ട് നോക്കിക്കേ. റൈറ്റ് കേസ് ഈസ് ഓക്കെ. ലെഫ്റ്റ് നോക്കമ്മ. താഴെ നോക്കമ്മ. മുകളിൽ ഒന്നുകൂടെ. Know what I'm going to do? Two things. Ma. No, not in also. കണ്ണ് മുറുക്കി അടയ്ക്കമ്മ.
Pels phenomenon is absent.
Okay, there is one point. മൂക്കിലോട്ട് നോക്കമ്മ.
Convergence.
നോക്കിക്കേ.
Defective. Left side is converging, right side is not that converging.
എറ്റം നോക്കിക്കേ. വലത്തോട്ട്.
Again, checking the movement once again, you can make out the decreased movement towards the
ഇടത്തോട്ട്
left
നോക്ക്.
side.
മുറുക്കി അടച്ച്. ഇനി പല്ല് കാണിച്ച്.
And some left human features, suspicious bilateral weakness.
ആണല്ലോ. ആന്ന് പറഞ്ഞേ.
Project was absent.
അടച്ചമ്മ. പതുക്കെ തുറന്നേ. വാ തുറന്നേമ്മ. ഇത് തമ്മിൽ വ്യത്യാസമുണ്ട്.
The decreased pain on the left side of the face and left side of the body.
നേരെ മുകളിലോട്ട് നോക്കി.
Okay, so that's the finding. So examination upward gaze restriction, tonic downward gaze deviation, Bell's phenomenon is absent, restriction of left lateral gaze, convergence defective, decreased pain on the left side of the face and body, restriction of movements of the parallel bilaterally, and jaw jet is absent. Motor power glossary normal, teeter or sluggish, standard left outgoing, tendinous incoordination the left side. Where is the localization?
Upper midbrain, sir.
Mondo midler.
Okay, upper midbrain implicate causing what all things you have to say? Is it upward gaze palsy due to the dorsal part of the midbrain? Agreed.
Because upward gaze is involved and convergence is involved in asymmetry on one side.
Okay, but two things you have to explain. Why there is a left gaze restriction to the left side? Why the abduction is more restricted than the adduction?
Because of the INO problem.
Here, sixth nerve nucleus is affected.
Pardon?
The sixth nerve nucleus is affected.
But sixth nerve nucleus is affected, it can be explained that. That means you have to bring down the lesion to the pons.
That left sixth nerve nucleus, because the lateral rectus plus left horizontal gaze palsy. Pons is also there.
Yeah.
This midbrain lesion is also present because of bilateral superior rectus involvement, because it is nuclear infranuclear lesion.
Perfectly right. You can have
All size Bell's phenomenon is absent.
Bell's phenomenon is absent. That when okay, used in upward gaze palsy, pure gaze palsy, Bell's phenomenon should be intact. But there's a forced downward deviation occurring sometimes in dynamic hyperstenosis. You may get absent Bell's phenomenon. That's apart from that. But as what Soumya was telling, when they have got a lateral gaze restriction to one side, and then abduction is more restricted, mean it's a abduction nucleus is affected, but down to the that part to the nucleus, the system is more affected than the gaze part. That's a good possibility.
Would that be due to MLF
But
lesion?
in that case, I would expect a normal convergence of the right hand.
Sir, I'd think of a thalamic lesion, thalamic or upper midbrain thalamic lesion, because this could be a convergent spasm. That need not be a system palsy on the left side. So it could be a convergent spasm that can affect the up gaze restriction.
Okay, right. So, what do you call that phenomenon? This I told some time back. I was on another case. It's called pseudo-abducent palsy. Okay.
Yes, sir.
Yes, convergent spasm causing pseudo-abducent palsy.
But this patient does not have convergent spasm.
Right. That's the thing you have to keep in mind. Any other possibility? How do you explain this dysphagia and able to solo?
Because of the pseudobulbar, because the corticobulbar in involvement, because the track.
So maybe pseudobulbar palsy.
If you want to localize to the thalamus, how can I explain the pseudobulbar palsy?
Maybe old corticospinal involvement, now the fresh corticospinal involvement in the midbrain.
Yeah, that's a good possibility. Patient maybe my old years of infarct occurring. Now the fresh infarct occurred on the right thalamus or the pyramidal tract. When the cerebral palsy has been unmasked, that part is agreed. But if the Georgic was brisk, I did not do the gag reflex.
Sir, a lesion in involving the thalami, like this paramedian nucleus, that can affect the upper midbrain also. The median mesencephalic, something like a mesencephalothalamic infarct, the artery of Percheron, something.
No, the artery of Percheron will not cause this kind of a problem. It is the affection of the thermoperforating branch of the midbrain which causes the upward gaze palsy in the midbrain lesions, PC infarct and all. But there, what happened that we should explain why the patients got the dysphagia. You can't explain it. Because it's a pyramidal tract is anterior.
Yes, sir.
This in thermoperforating involvement producing everything is dorsal midbrain. Okay. Right. Okay, let us see. But just like I told the last class, I am a favorite of Occam's razor. They try to explain everything by a single side as far as possible. So I would also prefer a lesion in the dorsal of midbrain rather than bringing down to the pons. That's my logically, because I want to localize to a single side. Let us see what is it. What, pardon?
So one doubt, sir. When she asked to look on the left side, the left eye is going downwards, but the right eye is also not adducting now, sir, completely.
You're perfectly right. That's what I said. It's got a left gaze palsy.
Yeah, that's right.
If the left gaze palsy is there, we expect equal degree of restriction of lateral rectus and medial rectus. Then only called a gaze palsy. In gaze palsy, you should not have any disconjugation. There should not be disconjugation, any gaze palsy. When there is a disconjugation, means that there is some kind of involvement of, in addition, there is a restriction of that muscle, either a lateral rectus weakness, as Omia was telling, or that eye is preventing from abduction because of the overact on the medial rectus by the convergence muscle. Okay, then also may appear like a lateral rectus.
So in this case, the overacting of the medial rectus on the both sides can cause.
Yeah, already right eye is more moving than the left side. So because of the adduction spasm or medial rectus spasm, which is present bilaterally, the left eye is prevented from moving towards the left side. Right eye is anyway moving medially. But that is not fully moving because already it's got a gaze palsy. You understood what I said?
Yes, sir. Then the upper midbrain lesion can explain everything, sir.
Explain everything. Only point is that it's got a pain loss of the face of the left upper and lower lip that you have to implicate dorsally more towards the right side. The spinatheric fibers are affected there and that spinatheric mid-tract before it enters the thalamus. That has to implicate in the right side. The gaze palsy to the left also can be explained by the involvement of the corticoreticulo, the quantum mesencephalic pathway, that is the pathway to the gaze palsy. That can use on the right side, mean left gaze palsy. Now I'll tell you, so look at the MRI now. Yes, no lesion in the midbrain. Is the right side of the thalamus is affected. There is another lesion of cerebellum which will come later on. We are not first concentrated on the eye finding. See, the thalamic nucleus is affected here. Again, thalamus is affected. No definite midbrain involvement. And how do you explain that thing? In fact, if we want to explain upward gaze palsy and yawn, we expect a lesion in the dorsal midbrain. The dorsal midbrain is intact. See, the dorsal midbrain is not affected. Or the other lesions of the right thalamus. And how to explain the bilateral palsy? Now, there is, Amya was thinking about the separate lesion here in this patient because he has got involvement of the cerebellum and bilaterally. That is probably he has got involvement of the lower medulla and lower medulla also may be affected. Here, some surgery is there to implicate the bilateral palsy. So anyway, forget about the bilateral palsy. I'm interested in the ocular movement. How to explain that thing with only thalamic involvement? Now, these are two things which you may not be knowing that there's entity called thalamic esotropia and thalamic vertical gaze palsy. I'll explain what it is. See, ophthalmoplegia in the context of ischemic stroke is typically thought to localize in the brainstem. Historically, even though in the previous thalamic stroke conduct, it was thought that it is due to the extension of the midbrain. It has been felt that the patient present with vertical gaze palsy, as a result of paramedial thalamic infarct, have associated dorsal midbrain involvement, as Umar was thinking about, that could not be detected on standard MRI. That is the thought. But time and again, this finding has been seen, where the brainstem is spared. Classical example is thalamic hemorrhage. You find invariably you find thalamic apposition. If you look at the midbrain, nothing there. However, it had been suggested that the isolated medial thalamic pathology could lead to vertical gaze restriction. The explanation they offer is that this is attributed to the interruption of supranuclear fibers as they pass through the medial thalamus on their way to control the control center in the midbrain. That's the postulate. Now, the other thing is the abduction, which already been discussed, is the phenomenon of contralateral abduction limitation even in thalamic lesion, even not implicating the convergent spasms. This is thought to due to convergent spasm itself, but the site of lesion. This is thought to represent a pseudo-abduction palsy caused by disruption of the descending inhibitory convergence pathways which pass through the paramedian thalamus before they decussate at the level of the subthalamic region to innervate the contralateral third octomotor nucleus, resulting in esotropia, that is inward movement of the eye, as a result of chronic activation of the medial rectus, mimicking an abducent palsy, contralateral to the thalamic infarct. That is when this patient has got an adduction, esotropia of the contralateral eye, producing the pseudo-abducent palsy. This thalamic esotropia is a transient phenomenon and usually variable, unlike systemic palsy, which is typically static and permanent. So this is explanation for the pseudo-abducent palsy in thalamic lesion, explanation for the vertical gaze palsy in thalamic lesion. So this is the summary of the finding. This is a case report again from the literature. Esotropia and vertical gaze palsy in patient acute thalamic infarct. That patient had lesion here without anything in the midbrain.
In thalamic esotropia, the eyes naturally should be looking towards the eye, sir. In this patient, even on convergence, you couldn't see the eyes fully converging.
No, that is a thalamic, what you said is correct. In thalamic eye position, what you see in thalamic hemorrhage, both eyes will be looking as if to the tip of the nose. Eyes will be converging and adducting and will remain like that. That is a classical thalamic eye position. But it can be confined only to one eye or more one eye. That is what is shown in this particular article.
So this may be a wrong way eye, sir, in this case.
No, this is not wrong way. No, wrong way is entirely different. Wrong way eyes is that in thalamic lesion, the eye deviation mimics that of the pontine lesion. So, for example, if you get a lesion here of the right thalamus, it will mimic that of a pontine. That gaze will be deviated to the gaze palsy to the right side, not to the left side. Gaze deviation to the left side. To opposite of what you expect here. Here the gaze palsy to the left side. If it's a wrong way eyes, you get gaze palsy to the right and deviation to the left side.
Okay.
That is the wrong way eyes.
Okay, sir.
Okay, any questions? Then we can stop.
The palatal involvement, bilateral palatal involvement.
Yeah, palatal involvement cannot be explained with the midbrain pathology or thalamic pathology. You have to implicate a separate lesion there. There are two possibilities, as you correctly said. One, the patient might have had infarct earlier, leaving because cortic bulbar involvement on one side. Another involvement is unmasked the palatal palsy. That's a good possibility. Or there may be an element lesion now because of the associated, there is infarct of the bilateral cerebellum, implicating that the medulla also might have been implicated because the inferior part of the cerebellum is also affected. The bicep. What I should have done is I looked for the gag reflex would have helped to differentiate the two. Georgic sometimes may not be elicitable all the time is the cerebral palsy. Gag reflex should be exaggerated if it is a cerebral palsy. But that I did not know I should have done. But the patient dying like that, we may not do all the tests in the bedside.
One more case, sir. One more eye movement.
One more eye movement you want? Okay, then you want eye movement. You have to search for it missing. Just 1 minute. Eye movement.
Sir, one doubt, sir.
Yeah, please.
Sir, if it is supranuclear pathway, sir, why this Bell's phenomenon should be absent?
Yeah, that's a very good question. Again, you have to there are two things which can happen. It may be palsy or it may be forced deviation.
Okay.
Forced deviation. That means thalamic hypotension and all. There's a forced deviation downward. What you said is perfectly right. In classical upward case palsy, you should not get the Bell's phenomenon to be intact.
Okay.
Even midbrain lesion can produce, if the Bell's center is affected, you can have Bell's phenomenon absent. Or maybe forced downward deviation, it can be, it may not be there.
Okay, sir.
Like a spasm occurring, like a gaze deviation or a spasm occurring there, this will be the phenomenon. I'm looking for an eye movement. Okay. I will show you this eye movement. Tell me what is the problem with it.
ഒരു നേരം നോക്കിക്കേ ഇവരിൽ നോക്ക് നേരം നോക്കി ഇതിലോട്ട് നോക്കിക്കോ ഓക്കെ നോക്കാം See the first step is 3 steps test. First step is which eye is
No, this I'm only explaining.
the right
So
eye
this is the Wilczowski notation.
or left eye is down. That means the depressors
Left eye is down, right eye is up.
or the elevators of the left eye is weak. The depressors of the right eye are superior oblique and inferior rectus. The elevators of the left side are superior rectus and inferior oblique. So we have got 4 muscles are weak now. Either these 4 muscles we have already mentioned. Now you want to look is in which direction the vertical separation is more. Here
Looking to the right
this side. Obviously this is more
on looking towards the left side.
This side.
Separation.
So, rather than here. Here also is separated, but much more separated here.
It's more separate to the left side.
Okay, correct? Yes. Okay. So this means this means that which are the muscles could be weak? No, I told you.
This position.
It means the right superior oblique is weak or left superior rectus is
The muscle which will be acting in this will be
left is weak, the right eye is down. Or right superior.
left superior. In that position, left superior rectus or right superior should be acting. Okay.
Right eye is up. So either right superior oblique is weak or the left superior rectus is weak. Okay. Now what you do, the 3 step, this second step is over. You turn, rotate, now you rotate, show the things. Okay. Show the turn the head,
Find out which direction it will be more separation.
it is increasing. Now see, on turning to the left side, the vertical discontinuation is
And this conjugation is less now on turning to the left side, more on turning to the right side, indicating what? When you turn to the left side, left interrotors are acting, right extrorotors are acting. On turning to the right side, right interrotors are acting, left extrorotors are acting. So here on turning to the right side, diplopia is maximum. That means the interrotors on turning to the right side are superior oblique and superior rectus. Or we suppose imagine that superior oblique is paralyzed. Only superior rectus is allowed to act to produce the interrotors to the right side. So when the superior rectus is acting, in that attempt, what will you do? It pulls the eye upward because the other action of superior rectus is elevation. Already the right eye is at higher level. It made further up by the action of superior rectus, which is unopposed by the inferior action of the other interrotor, that is the superior oblique. So what happened with right eye goes up. Superior oblique normally is a depressor. The depressor action is not there. Only superior rectus alone is acting. So superior rectus takes eye up, further up. The diplopia will become more manifest when you turn the eye to the affected, tilt the head to the affected side. That is why the patient now complains of more diplopia and the disconjugation is also more.
is more or less.
They are telling more.
It is increasing.
For turning to the left side, the vertical disconjugation has become disappearing.
On turning to the left side, the vertical
Diplopia is
discontinuation
become
is
less.
less.
So what is this test known as?
Bershowski.
Wilczowski sedentary. This is a 3-step Wilczowski. I don't think I could not show any other ocular movement. Someday, I think the next class I will show you because I have to choose. Okay, I will show you one. Okay, I will show one. Are you able to see? Can you see the video?
No, sir.
Hello?
No, sir, you can't see.
Are you able to see my video?
No, sir.
No, sir.
No. Okay. Right. That's some problem. I'll have to stop share and then show the video. Well, no one thing. Next class I will show that better. You're getting stuck again.
Okay, sir.
Okay, sir.
Sir, one doubt regarding the pachymeningitis case, sir.
Hello, am I audible to you?
Yes,
Yes,
sir.
Yeah, you want to show now or next class? I can
Sir,
show. Eh? Some people have already left. I think we'll show next class. Okay.
sir, one doubt regarding
Yes,
the
sir.
tuberculous pachymeningitis, sir.
Yeah. Tell me that. Yeah.
Sir, is it CSF TB PCR is necessary in that case, sir? Because polymorphs are also seen around 50% in that case.
Yeah. TVPCR is not required ideally because as far as my experience is concerned, TVPCR positivity I have hardly ever seen, except probably one or two cases. Even gene expert also most suspected or almost sure case of TBM, they become negative. So I don't go by this test at all. The sensitivity is very low. I don't know, it's a problem with my lab. I think it's wherever I have, but I have gone this experience, they are also taking. So that's not required all the time to make a diagnosis.
So one more doubt regarding that thalamic stroke, sir, is the gag reflex helps to differentiate whether additional lesion in the pons is there or not for medulla.
Exactly. We want to differentiate whether the inability to swallow or the bilateral parietal weakness is due to bilateral UMN, or that's a part of cerebral palsy, or bilateral LMN, a part of a bulbar palsy. Differentiate LMN versus UMN, the reflex you have to look for is the gag reflex. Gag reflex is brisk, means it has to be UMN. If it is absent, it can be either way, but more likely. That's why you want to look for a gag reflex.
Okay, sir. Thank you.
So, thank you all. We'll see you next week. Okay, bye.
Bye, sir. Thank you, sir.
Yes, sir. Bye, sir.
Bye. Bye.